Imagine you suffer a massive stroke. You're rushed to the hospital. The neuro team successfully pulls this clot out of your brain, and now you're recovering in the ICU.
Right, the critical period.
Exactly. And suddenly your blood pressure spikes to like 175/95.
Which is high. Very high.
Yeah. And for decades, if a nurse saw that on the monitor, I mean, that meant hitting the panic button, right?
Yeah.
You aggressively push medication to bring it down. But today, according to the brand new 2026 AHASA guidelines for the early management of acute ischemic stroke.
That ICU doctor intentionally letting your blood pressure run that high, that isn't malpractice anymore.
It's the gold standard.
It is. And it completely upends our traditional clinical instincts. I mean, we are trained from day one in med school to normalize abnormal numbers.
Right.
But the new data is really forcing us to accept that the recovering brain operates under a, well, completely different set of physiological rules.
Which is the core mission for our deep dive today. So, to you listening, whether you're a neurologist, an ER nurse, maybe an EMT, or just someone who's, fascinated by how fast medical science is moving.
Because it is moving incredibly fast right now.
So fast. We are unpacking the massive, highly anticipated 2026 guidelines. And as you dive into these sources, you realize pretty quickly this isn't just a document of minor clinical tweaks.
No, not at all.
We are witnessing a fundamental shift here, away from a generalized sort of rush and treat model towards something highly precise, physiologically driven, and honestly heavily reliant on advanced technology.
Yeah, the foundational philosophy of stroke care has always been time is brain. That hasn't gone away.
Right, because every minute an artery is blocked.
Roughly 2 million neurons die.
Exactly.
But what these 2026 guidelines reveal is a total evolution in how we actually manipulate that time. We've kind of stopped just racing against the clock and started changing the nature of the race entirely.
I want to start exactly there, actually, with the race itself, because that timeline begins way before the patient ever hits the hospital doors.
Oh, absolutely. Out in the field.
Yeah, so we're looking at a major update regarding mobile stroke units, MSUs. The guidelines have issued a Class 1 recommendation for using MSUs over conventional EMS for thrombolytic-eligible patients.
Which is their absolute strongest endorsement.
Right. But, let's explain what that is.
So the shift here is literally moving the emergency room to the patient's driveway. An MSU isn't just a fast ambulance with flashing lights. It's a specialized neuroresuscitation bay on wheels.
Wow.
You've got a mobile CT scanner on board, point-of-care lab testing, and personnel who are equipped with a real-time telemedicine link to a vascular neurologist.
See, on paper, bringing the scanner to the patient sounds incredible, but I have to push back a little on the logistics here.
Sure.
Because outfitting a whole fleet of ambulances with heavy, highly sensitive CT scanners, that sounds like an incredibly expensive PR flex for a hospital system.
Yep.
Does the time saved actually translate to a measurable difference in a patient's life? Like, is it worth it?
Well, the health economics of MSUs were heavily debated for years for that exact reason. People ask that exact question. But the guidelines lean on two major trials. The BPROUT trial and the BEST MSU trial.
Okay.
And they definitively answered it. It's not a flex. It is a paradigm shift.
Yeah.
The trial showed that MSUs drastically increased the frequency of ultra-early thrombolysis.
Meaning treating within the first golden hour?
Right. When you treat a stroke within the first 60 minutes of symptom onset, that cascade of neuronal death hasn't fully accelerated yet.
Okay.
So by diagnosing and pushing the IV medication right there in the driveway, instead of waiting for ear triage, MSUs cut the onset to treatment time by 30 to 40 minutes on average.
That's massive.
And that specific window of time tangibly improves 90-day functional outcomes. It is the literal difference between a patient eventually walking unassisted versus requiring long-term nursing care.
So the data literally proves those 30 minutes are the most expensive, valuable minutes in the entire timeline.
Exactly. And crucially, the trials showed absolutely no increase in safety concerns.
Really? No extra bleeding?
Symptomatic intracerebral hemorrhage rates were no higher than if the patient had been treated in a standard hospital setting. So the speed is safe, and the speed saves tissue.
That raises the next massive question, though. Once that MSU arrives on the scene, or, the patient is rushed through the traditional ER doors, what exactly goes into their face?
Yes. The medication update.
Because the 2026 guidelines just dethroned a medication that has been the undisputed king of stroke care for, nearly 3 decades?
Yeah, alteplase. And this transition from alteplase to tenecteplase for the standard 4.5-hour treatment window, it's arguably the most practice-changing update in the entire document.
Wow.
tenecteplase, specifically at a dose of 0.25 milligrams per kilogram, is now the recommended standard. And this is based on massive global phase 3 trials like TRACE-2, TASTE, and ORIGINAL.
Okay, to understand why this is such a revolution, I think we have to look at the mechanics of the old drug, right? Alteplase.
It was notoriously complicated.
Extremely. The pharmacy has to mix it. You push a 10% bolus into the IV, and then you have to hook the patient up to a pump for a meticulous 1-hour continuous drip.
Which is just an absolute logistical nightmare in a chaotic emergency environment.
Right.
I mean, imagine you have a patient who needs to be urgently transferred from a community hospital to a comprehensive stroke center for a mechanical thrombectomy. You're trying to move them onto a helicopter.
Or bouncing around in the back of an ambulance.
Exactly. And they are tethered to an IV pole delivering this highly sensitive, life-altering medication. If that line kinks, or if the pump fails during transport, the treatment just stops.
And tenecteplase completely eliminates that problem.
Completely.
Because it's given as a single push, 5 to 10 seconds, and you're done. I always think of it like taking a quick shot of espresso versus waiting for meticulously crafted pour-over coffee while your kitchen is literally on fire.
That is a perfect analogy.
But why can tenecteplase survive as a single shot when alteplase needs a full drip? Like, what is the chemical difference there?
Well, it really comes down to pharmacokinetics and bioengineering. Tenecteplase is actually a modified version of alteplase. Scientists tweaked the amino acid sequence to give it two massive advantages.
Okay.
First, it has a much longer half-life, meaning it stays active in the bloodstream significantly longer, which is what allows for that single bolus push.
That makes sense.
Second, it is highly fibrin-specific.
Meaning it targets the clot more aggressively.
Right. It binds directly to the fibrin mesh that holds the blood clot together, rather than just circulating systemically and breaking down clotting factors everywhere in the body.
Oh, wow.
Yeah, this makes it incredibly efficient at busting the specific occlusion in the brain without necessarily increasing the systemic bleeding risk.
That perfectly explains why it drastically cuts down on door-in, door-out, or DIDO times. The patient gets the shot, and they are immediately untethered and ready for transport. But the guidelines do include a pretty massive flashing warning sign regarding the dosing, don't they?
They do, and it targets a very common bias in medicine. We often assume that if a standard dose of a drug is good, a higher dose might be better for a particularly stubborn clot.
Right. More is more.
But the NORTEST-2 trial tested this exact hypothesis. They compared the standard 0.25 milligram per kilogram dose of tenecteplase against the higher 0.4 dose.
I assume the higher dose caused more bleeding.
It was actively harmful.
Wow.
The higher dose showed absolutely no additional functional benefit, but it did show a potential for worse outcomes. So the guidelines are unequivocal here. The 0.4 milligram dose is strictly not recommended. Precision is paramount.
So no improvising.
None. The 0.25 dose hits the exact pharmacological sweet spot where the drug dissolves the occlusion without tipping the brain into a catastrophic hemorrhagic state.
It's a delicate tightrope. So tenecteplase is our new precision tool, provided we are within that strict 4.5-hour window from the onset of symptoms. But let's look at a scenario that happens all the time. Someone goes to sleep at 10 p.m. feeling perfectly fine. They wake up at 7 a.m. with left-sided weakness. The clock says 9 hours have passed.
The dreaded wake-up stroke.
Exactly. Historically, missing the window meant missing the treatment. The risk of bleeding was considered too high, and the patient was just relegated to supportive care.
That was the tragic reality. The 4.5-hour mark was this ironclad barrier because we were using the clock on the wall as our only metric for how much brain tissue had died.
But the new guidelines feature an expanded 4.5 to 9 hour window, along with specific protocols for those wake-up strokes. But wait, I'm stuck on the timing here.
Yeah.
If the clock says 9 hours, the window is closed. How are you measuring time if not with a clock? Are we looking at the actual physiological decay of the cells?
That is exactly what we're doing. This is the shift from chronological times to biological time.
Okay, how?
We measure this using advanced imaging, automated CT perfusion or MR perfusion. To really understand how this works, you have to visualize the stroke not as a single dead zone, but as a dynamic landscape.
Okay, map that out for us. What does that landscape look like?
So when a clot completely blocks a cerebral artery, the tissue immediately downstream dies very rapidly.
Sure.
That is the infarct core. It is gone. We cannot save it.
Okay, that's the core.
But surrounding that dead core is a much larger territory called the penumbra. The penumbra is starved of blood It's electrically silent, meaning the patient has paralysis or loss of speech,
Yeah.
but the tissue itself is structurally intact.
Oh, wow. So it's not dead yet.
Right. It's on the brink of death, but it is salvageable.
So how does the perfusion software tell the difference between the core and the penumbra if they both lack blood flow?
It's brilliant, really. The software measures two distinct things, cerebral blood flow and cerebral blood volume. In the dead core, both flow and volume are completely absent. Exactly. But in the penumbra, the flow is severely reduced. But the local blood vessels have maximally dilated. They've widened as much as physically possible to pull in whatever collateral trickle of blood they can find.
So they're holding on to whatever they have left.
Yes. So the blood volume is somewhat maintained, and the software color codes this difference.
Ah, so the doctor can look at the scan and literally see a small red area of dead core surrounded by this massive green area of struggling penumbra.
That is the mismatch. If advanced imaging shows a favorable mismatch, a small core, but a large salvageable penumbra, the guidelines state we can confidently administer fade thrombolysis up to 9 hours out.
That's incredible.
Or even when the exact time of onset is totally unknown. We are treating the physiology of the brain, not the hands on the clock.
That fundamentally changes who gets a chance at recovery. Okay, so we've busted the clot, or perhaps the neuro team went in and physically removed it with a stent retriever. Blood is flowing again.
The patient is in the ICU.
Right. Which brings us back to that provocative scenario from the very beginning, the less is more paradigm.
This is where standard medical training collides with rigorous trial data.
Let's start with blood sugar. Because if I'm an ICU nurse and I see a stroke patient's blood glucose creeping up to like 160 or 170, every instinct tells me to start an IV insulin drip.
Of course.
We want perfect textbook numbers, say 80 to 130 milligrams per deciliter, because a recovering brain needs a perfect internal environment, right? Why would I ignore that alarm?
Because treating the number on the monitor actively harms the patient.
Really?
The guidelines heavily reference the SHINE trial, which tested this exact clinical instinct.
Right.
They randomized patients to either intensive glucose control, targeting that strict 80 to 130 range.
The textbook normal range.
Right. Or a standard looser target of 140 to 180.
And pushing it down to normal didn't help.
It didn't just fail to help. The trial actually had to be stopped early for futility and safety concerns. Pushing the glucose down to normal offered zero functional benefit at 3 months. But it significantly increased the risk of severe, dangerous hypoglycemia, dropping the blood sugar below 40.
Which is catastrophic.
It's instantly devastating. We just talked about the penumbra, that fragile, struggling tissue holding on for dear life. It is completely starved of energy.
Oh, I see.
If you accidentally induce hypoglycemia trying to make the chart look perfect, you deprive that already starving tissue of its primary fuel source.
So it's a J-shaped curve then. Like high blood sugar is bad because it causes inflammation, but low blood sugar is an immediate threat to the penumbra. So the sweet spot is actually a bit elevated.
Exactly. The new recommendation is a permissive target of 140 to 180 milligrams per deciliter. Less intervention is actually more protective.
Okay, I can wrap my head around the glucose, but the blood pressure recommendations, those are genuinely shocking.
Yeah, they take some getting used to.
Because high blood pressure is usually what caused the stroke or the vulnerability in the first place. Once the artery is open, surely we want that pressure down to a calm, normal 120 over 80 so we don't blow out the newly opened vessel.
That was the assumption for decades. But let's look at the data for patients after a successful endovascular thrombectomy. When the surgeon physically pulls a large vessel occlusion out. Right. The trials, specifically Optimal BP and BEST-2, looked at what happens when you aggressively lower the systolic blood pressure to under 140.
And the guidelines now classify that as a Class 3 recommendation for harm, not just futile, harmful.
Harmful. Intensive blood pressure lowering leads to worse functional outcomes and larger final infarct volumes. The brain tissue literally dies faster when you normalize the blood pressure.
That's wild.
And for patients receiving 5E thrombolysis, keeping them under 140 is similarly not recommended. The target is a surprisingly high 140 to 180.
This is where I really need you to explain the underlying physiology. Why does a bruised, recovering brain actively need systemic high blood pressure? Because it just sounds so counterintuitive.
It requires understanding cerebral autoregulation. So in a healthy brain, local blood vessels constrict and dilate continuously to maintain a steady flow of blood regardless of what your systemic blood pressure is doing.
Like if I go for a run.
Exactly. If you go for a run and your blood pressure spikes, The vessels in your brain constrict to protect the tissue from that high pressure.
But a stroke destroys that mechanism.
Completely.
Yeah.
The local vessels in that ischemic penumbra lose their autoregulatory ability. They become paralyzed and, like we said earlier, maximally dilated.
Oh, right.
Because they can't regulate themselves, they become entirely dependent on the sheer force of the systemic blood pressure to push blood through the collateral pathways.
It's like trying to water a garden with a kinked, leaky hose. The only way to get water to the end of the line is to turn the spigot at the house on full blast.
That is precisely what is happening. The brain is swollen, intracranial pressure is slightly elevated, and those tiny collateral vessels need a massive pressure gradient to force oxygenated blood into the dying tissue.
Wow.
If you drop the systemic pressure to 120/80 just to satisfy a textbook definition of normal, you eliminate that pressure gradient. You literally starve the salvageable tissue that you just worked so hard to open the main artery for.
We're treating the physiology, not the monitor. It is a brilliant reframing. Now, we've spent this entire deep dive talking about how to manage these delicate internal pressures and, utilize advanced tools in adult vessels.
Right.
But that generalized approach completely falls apart when the patient is a child, right?
Yeah.
You can't just scale down adult tools for pediatric anatomy. And yet, for the first time, these 2026 guidelines include specific endovascular thrombectomy recommendations for children.
It is a monumental step forward for a highly vulnerable population.
Yeah.
I mean, pediatric stroke is relatively rare, but when it happens, it is a devastating cause of lifelong brain injury.
I can't even imagine.
Up until now, pediatric neurologists essentially had to extrapolate data from adult trials because there simply wasn't robust pediatric data available.
Which is terrifying for a practitioner, but now we have the Save Child's registry data.
Yes. The registry provided the evidence needed to formalize these guidelines. They state that EVT, navigating a catheter into the brain and pulling the clot out, can be highly effective and is recommended for children who are 6 years and older who present with a large vessel occlusion within 6 hours.
Okay.
And like adults, that can be extended if advanced imaging shows a mismatch.
I have to ask about that specific age cutoff, though. Why 6 years old? Is there some developmental milestone there?
It is purely anatomical. By the age of 6, a child's intracranial vessels have grown to be nearly adult-sized in terms of their internal caliber.
Oh, I didn't know that.
Yeah, so that means the microcatheters, the aspiration devices, and the stent retrievers that neurointerventionalists use every day for adults can safely navigate a 6-year-old's vasculature without causing catastrophic damage to the vessel walls.
But strokes can happen to toddlers and even infants. The guidelines do mention children aged 28 days to 6 years. What happens in those cases?
The guidelines carefully state that for the younger cohort, from 1 month to 6 years old, EVT may be reasonable, but the technical caveat is massive here.
Because the vessels are so small.
No, exactly. The vessel caliber in an infant is drastically smaller and incredibly fragile. You cannot use standard techniques. The guidelines stress that these cases require an incredibly specialized neurointerventionalist with specific pediatric endovascular experience, usually at a dedicated pediatric stroke center.
The sheer technical skill required to navigate a microcatheter into the brain of a 2-year-old and extract a clot. I mean, it's staggering to think about. It is at the absolute bleeding edge of human medical capability.
It really is. But the registry data proves that when it is done by experienced hands, reestablishing that blood flow can literally give a child an entire lifetime back.
Which brings us to the core of why we are unpacking all of this today. We've covered an immense amount of ground.
We really have.
We've seen how stroke care is becoming faster, shifting the starting line to the driveway with mobile stroke units. It's becoming sharper, moving from cumbersome, continuous drips to single-shot, fibrin-specific drugs like tenecteplase.
Exactly.
And it is becoming deeply counterintuitive, forcing practitioners to ignore alarms and allow the brain the permissive hypertension and glucose levels it actually requires to heal.
I think the overarching theme of the 2026 guidelines is the death of protocolized dogma and the rise of highly individualized, physiologically driven care. We are finally treating the patient's specific biology in real time.
And to you listening, understanding this evolution is empowering, whether you are actively working in the field or just, arming yourself with knowledge for your family. Knowing that standard targets are shifting changes the questions you ask in an emergency. It really highlights the unbelievable pace at which this science is advancing.
And if I can leave you with a final thought to mull over.
Please do.
Something that bridges the guidelines of today with the reality of tomorrow. We just spent significant time discussing how broad, intensive blood pressure targets, like 120 over 80, are actively harmful, and that the new targets are 140 to 180.
Right, the permissive hypertension.
But the guidelines identify a massive gap in our current knowledge. They note an urgent need for trials assessing individualized blood pressure targets because, honestly, even 140 to 180 is still just an educated guess based on an average. What if the future of stroke care isn't about general brackets at all?
Well, where are we getting the data if not from a bracket?
From real-time cerebral perfusion biomarkers.
Oh, wow.
Imagine a near future where AI and continuous non-invasive sensors are reading your brain's collateral flow millisecond by millisecond. The machines won't tell the ICU doctor what the average human brain needs. They will tell the doctor exactly what your specific brain needs, right in that exact moment to keep the penumbra alive.
That brings us full circle. We used to look at the brain like a static image, broken or not broken, treated or not treated. But the brain isn't static. It's a dynamic, desperately adaptive ecosystem. And we're finally developing the physiological understanding and the technological tools to meet it where it is. Thank you so much for joining us on this deep dive. Keep questioning the standard answers, keep learning, and we will catch you next time.